children around the world. So when we think about customizing and precision medicine care, this is an example of gene therapy. This was the first drug for gene therapy for SMA, for spinal muscular atrophy, where the price point for one injection is $2 million. Today, the price point for the costliest drug on the market is gene therapy for sickle cell anemia, where it's almost close to $4 million an injection. We have to think about affordability, accessibility, and sustainability as we move towards bespoke care for patients. Nonetheless, I think the future is bright. I think there are ways to responsibly and sustainably use approaches that can make more precise and personalized care to improve outcomes after transplantation. So with that, I just want to thank the funders. I do want to thank the CDTRP for funding some of the work that I presented and our positive collaborators. Thank you.
Excellent. Thank you very much, Dr. Mittal, for that visionary talk. And so our final speaker of the session is Dr. Tom Blydt-Hansen. He's going to be presenting on non-invasive monitoring of graft rejection. And he completed his MD at McGill University, training in pediatric nephrology at Montreal Children's, and then transplantation at UCLA. And as you've heard this morning, he's held leadership roles, including division head at the University of Manitoba, and he's currently director of the multi-organ transplant program and senior scientist at BC Children's Hospital. His research focuses on non-invasive biomarkers in the urine for pediatric kidney transplant recipients. Thank you.
Great. Well, thank you very much. I'm conscious of the fact that I'm between you and your lunch. But I think this is an important follow-on to both of those talks. And just for Dr. Halloran, you got a rousing round of applause, but I think the mute button was on, so I don't think you heard that. But this is really in some ways an extension of some of what he discussed. These are my disclosures. I'd just like to say that although I receive funding, I don't have any consultant or speaker relationships with any of the industry partners that I work with. I'm hoping that at the end of this, I decided to take a little bit of a different take, which was to perhaps help to equip all of us with a better understanding of how to evaluate this research and how to do this research, while I'm also discussing some of the data that currently exists, which is to say to have an appreciation for the clinical validity of existing biomarker tests, and then hopefully to apply those standards to how we will do research going forward. I guess one other thing that I will mention is that I'm not going to be discussing antibody-mediated rejection, and that's because our focus has been really more on the early rejection episodes in terms of T-cell mediated rejection, which we think have an important role in programming the immune response ultimately towards those chronic forms of allograft inflammation. The problem that we face, I think, as you all know, is that the current clinical monitoring tools that we have are really ineffective, especially for subclinical rejection. And so there's this real appetite by clinicians and researchers to discover better ways to monitor our patients. And this speaks to, David already presented a version of this slide, but this speaks to some of the challenges that we have, which is that subclinical, acute rejection is in many ways a precursor to longer-term forms of rejection. In this case, we're looking at the presence of antibody-mediated rejection. But we know that both the first acute rejection as well as unresolved acute rejection, in addition to other risk factors like being a younger age group such as pediatric, all have important roles to play in terms of the long-term graft survival. And we know that creatinine is really not a very good biomarker. When we look at studies that include both indication biopsies and surveillance biopsies, the left-hand panel is the normal, the right-hand panel is those patients with rejection. It's not hard to see that these are very much superimposable. And as a test in of itself, especially for subclinical rejection, it goes by definition, creatinine is not a good marker of subclinical rejection. And so it really argues for us the need for us to find another test. And this is underlined by the fact that we know that subclinical rejection is deleterious to long-term graft outcome. This is looking both at subclinical T-cell mediated rejection as well as borderline T-cell mediated rejection. And you can see, and this is Mike Seifert's data, you can see that there's a substantial difference in terms of the long-term graft outcomes in these patients. And so really there's a need for a better test than creatinine. So I'm going to talk a little bit about how to approach some of these biomarker issues. And there's a whole landscape of transplant omics that we look at, and this goes from the genomic and genetic risk factors of both the donor and recipient, and how they play into mismatching and alloimmune risk, through to the immune response that we get that's initiated by transcription of genes into messenger RNA, the further elaboration of proteins related to those, and then the biochemical reactions that those proteins mediate, which is the field of metabolomics. And ultimately, those changes in the tissue result in injury, which can be measured and which can be seen histologically, and ultimately result in a clinical phenotype, which may be a deterioration in kidney function or proteinuria. But we don't want to wait till the right-hand end of the slide before we start to make a diagnosis of rejection. We'd really like to move this process as far to the left as possible, ideally predicting who's going to have rejection in the first place, but if not, to identify as early on in the possible when somebody's developing T-cell mediated rejection. But all of these are potential targets. So I'm going to just review 3 or 4 big issues in terms of how biomarker studies are reported. The first has to do with what we call acute rejection. So you'll notice in my slides, I don't talk at all about acute rejection. Antibody-mediated rejection is not the same thing as T-cell mediated rejection. There are obvious differences both at a molecular and at a cellular and at a transcript level that distinguish those two things. And so when we design biomarkers to identify one or the other, conflating those together as acute rejection really doesn't make a whole lot of sense. Sure, at the more severe end of the spectrum, they will all ultimately manifest as acute kidney injury and a change in the clinical functional phenotype. But if we were doing a study of heart failure, we wouldn't compare people with incipient heart failure to those people who have end-stage heart failure. So we really, if we want to identify those people who are at risk or who have early stages of disease, we need to identify those patients early on. The second is the need for surveillance biopsies to identify subclinical rejection. And as Phil alluded to, there's a gold standard that is necessary to identify rejection, which is a biopsy. And I would argue that based on Phil's and other people's data, we should actually be looking at the transcriptomic diagnosis of rejection when we're developing these biomarkers. But currently, the best standard that we have is the biopsy. But that has to be context specific. So again, looking at somebody with rejection who's got graft dysfunction is not the same thing as identifying or monitoring for rejection in somebody who does not have graft dysfunction. So why would we not use indication biopsies? Well, the first thing I'll say is that indication biopsies may be useful from a mechanistic perspective if we're trying to understand the pathophysiology of rejection. But if we're looking at trying to identify a test that identifies subclinical rejection, the problem with using patients with AKI in that context is that there will be additional confounding effects on those biomarker profiles. Those relate to those transcripts and cytokines and metabolomic changes that are resultant from the tissue injury itself, which is manifest as kidney dysfunction, as well as in the case of kidney failure, the changes that accrue with uremic changes will also have an impact on those markers. And the second is that patients who are presenting with acute kidney injury may and likely have had a more tracted or a more acute or more severe presentation of that injury. And that may be different in someone who's presenting with subclinical injury. And we certainly see in subclinical rejection far, far more borderline changes than we do BANF1A or 2 forms of rejection. And so those patients who present with indication biopsies may also have much more chronic injury that has accrued over time in addition to the acute or active changes. The third thing is, when we go to the clinic every day, one of the questions fundamentally that we ask is, does my patient need a biopsy today to exclude acute rejection? And this requires us to have a test that tells us when to do a biopsy. And I want to talk a little bit just for a second about the fallacy of the negative predictive value, because you see this marketed as a reason to use some tests to exclude the need for a biopsy. So the first is to say that when we look at negative predictive value, it's really important to understand what the prevalence is of the disease that you're trying to detect. This is the biopsies in the first 2 years after transplant at our center by surveillance. We see that the highest prevalence of any form of rejection is at 6 months post-transplant at nearly 30%. However, only about 7% of those are actually BANF1A. And if you go beyond 1 year, most rejection is 1 to 2% prevalent at best. And that's to say that any random patient who shows up at your clinic is or isn't likely to have rejection. That's probably less than 2%. So keep that 2% number in mind. So this is just a 2x2 table to calculate your positive and negative predictive value. So let's say you've got a test that you say has a good test, or at least a fair test, 75% sensitivity, 95% specificity, and this assumes a 2% prevalence of your disease. And what you see is that your positive predictive value is around 23%. You may say that's not great, but recognize we do surveillance biopsies with the expectation of seeing rejection anywhere from 10 to 30%. So this is not outside of the range of what we would see for most surveillance biopsies, and certainly better than what we would see at a surveillance biopsy at either 3 months or 12 months. And obviously a very high negative predictive value. So basically you need to do 4 biopsies in this case in order to detect 1 episode of T-cell mediated rejection. This is a not good test. So this is a test with 10% sensitivity, similar specificity. And when we look at the negative predictive value, still 98%. Why is that? It's because the prevalence is 2%. And whatever test you do, if you do a pregnancy test on everybody in your clinic, it's also going to have a negative predictive value of 98% as it relates to T-cell mediated rejection. So in this setting, you'd need 25 tests in order to actually identify 1 case of T-cell mediated, 25 biopsies for positive tests to diagnose 1 case of acute rejection, but you'll also miss 90% of the cases of acute rejection. And so this isn't a good test. And so if I was to say it a different way, if you're looking for a needle in the haystack, it doesn't help to have a test that reliably identifies the hay. You want to be able to identify the needle in the mix. So the next little bit, I'm just going to go through what are some of the existing or proposed biomarkers that are useful for detection of subclinical rejection. And we're going to go through these 4 types of biomarkers fairly quickly. This is the construct that I'd like to use. First, just to quickly identify what the biomarker is measuring, to get a bit of an understanding what else this biomarker will pick up, rather than just acute T-cell mediated rejection, whether or not it's been accurately validated for TCMR, whether it's been validated for subclinical TCMR, and then finally, whether it's been validated for subclinical TCMR in children. And at the end, I'm going to go over a little bit the need for implementation trials, because this is actually a desperately needed area in this field. So firstly, just to use the paradigm for creatinine, we know what creatinine measures. It measures kidney injury and specifically GFR. We know what else causes an increased creatinine. It is certainly validated for more severe T-cell mediated rejection. It definitely detects it, but it is not good at detecting, obviously, subclinical rejection. And we know that actually even in children, it's actually got worse sensitivity for rejection because of donor-recipient size mismatches that come with pediatric transplantation. All right, just clicking away. There we go. So donor-derived cell-free DNA. So as you've heard already, this is a blood-based system to identify genetically different circulating DNA that's attributable to the donor allograft. And typically, this is measured as a percentage of circulating DNA, usually with more than 1% identifying people who have a significantly elevated level of donor-derived cell-free DNA. Now, we do know that there are other things that cause elevated cell-free DNA. It's a marker of graft damage. It's a marker of cell death in the allograft. And any type of kidney injury in the allograft is going to give you cell death in the allograft and may cause an elevated cell-free DNA. Most studies that have been done looking at rejection specifically have unfortunately conflated T-cell mediated rejection and antibody-mediated rejection, with most of the signal coming from the AMR side of the spectrum. And so that makes it very difficult to understand, does this test actually identify T-cell mediated rejection? So there's 4 studies that looked at that, and I'm just going to show you the 2 that are the most helpful. This is the Admiral study by Bu and another study by Gupta. Together, they had just over 350 adults who had transplants and who had monitoring with biopsies, and of those, there were about 65 with T-cell mediated rejection. And what you see is that, firstly, this isn't a great ROC curve in terms of the specificity, but it was, they did not report the 95% confidence interval. So I can't actually say whether this was a significantly increased or a significantly useful biomarker. And the median cell-free DNA actually in the T-cell mediated rejection group, which was reported as a sub-analysis without any p-values or other confidence intervals, was 0.67 to 0.7. And if you remember the threshold being greater than 1% being sort of a common threshold for the diagnosis of rejection, you can see pretty quickly that this isn't all that useful. Now, the best study that was done, published most recently, was by Aubert, and that was just recently published in Nature Medicine. They had over 1,400 biopsies, and they actually were able to show that patients with T-cell mediated rejection, at least at the extremes of rejection, had elevated cell-free DNA. And the mean that they reported for all T-cell mediated rejection was a cell-free DNA of over 2%. But when you look at the graph on the right, you see that it was actually the I3 lesions that predominantly identify patients with T-cell mediated rejection. If you look at these I1 and I2 lesions, you can see that these are actually hovering around the 1% range. Same thing for the T lesions. It's mostly the T3 that are attributing much of the score. And there was likely a disproportionate weighting of the number of people with severe T-cell mediated rejection that contributed to this population. They did not, unfortunately, report T-cell mediated rejection separate from antibody mediated rejection. So they have a report for subclinical rejection. They said that subclinical acute rejection is significantly higher cell-free DNA, but they actually didn't report which component of that was TCMR, which was ABMR, and they didn't report any other test performance characteristics. So even with a study of 1,600 patients, they weren't able to establish clearly whether this is a useful test for monitoring of my patient who's got a normal creatinine to detect subclinical rejection. This is the only study that I can find that actually looked at surveillance biopsies. They didn't do any statistical comparison between the groups, but in this study, those patients with subclinical TCMR of all types had a median cell-free DNA of 0.5 compared to 0.23 in the no rejection group. All right, and then the last is that, unfortunately, none of this has been well validated in children. Dan DeMudi and Darnadarka and colleagues have done a couple of papers that report on this. This is a combination of a subclinical and clinical rejection. And you can see when you include the clinical rejection episodes, you can see a potentially relevant classifier, but they did not report separately the subclinical TCMR. And what I've heard from them in discussions with them about their data is that although there was a large number of surveillance biopsies in the study, the large majority of those samples that had rejection were indication biopsies. And so that really skews how those data can be reported. And they didn't, unfortunately, report on the subclinical population on its own. So I spent the most time on that one because that's really the test that has gotten out there into the public vernacular. And unfortunately, I have to say there's no data at all to support using cell-free DNA for routine surveillance in pediatric kidney transplant recipients, period. The metabolomics is something that I've been working on. Metabolomics is an interesting discipline that looks at all the molecules of metabolism that are both substrate and end products of those metabolic pathways. But in particular, we're looking at the patterns of change. So because metabolism is so interconnected, looking at the patterns of those changes in those metabolites is very informative, much more informative than any individual metabolite on its own. And so we're interested in looking at these multi-metabolite panels as predictive processes. And so we know what it does. We look at the changes that presumably are associated both with the injury to the tissue related to the stage of injury in the kidney, as well as those metabolites that are attributable to the infiltrating cellular pool of immune cells. And what we do is just calculate a discriminant score, which is a way of reducing the data to a single variable that describes the likelihood of rejection or no rejection. And we do that training and then validate it in an independent data set. So these are just a very quick summary of some of the data that we've published so far. This is a discriminant score that's got an AUC of 0.81, statistically significantly different from the creatinine, which is the dotted line here. This is pediatric data. This is looking at only the surveillance biopsy. So this is validated in children for subclinical rejection for T-cell mediated rejection. This type of approach has been validated by multiple other studies. One of the really interesting aspects is if you look at the list of metabolites that each of these studies reports, they're actually all different. And that relates to the fact that there's multiple redundancy in the metabolome in terms of describing one or another cellular process. And so perhaps not surprisingly, although we're measuring the same thing, most of us, depending on the mix of patients, will come up with slightly different profiles in terms of which metabolites are the most important. Urinase cytokines and chemokines, David alluded to this before. So CXCL9 and 10 are the two that we're most interested in. This is a CXCR3 family of cytokines that are induced by interferon gamma that's produced both by inflammatory cells as well as some native renal tissues. And they're chemotactic drugs, and they're particularly prominent in the Th1 response. So we know what they do. This is a test for inflammation. So this is not specific for rejection. And we know that all forms of inflammation in the kidney will all Th1 driven forms of inflammation in the kidney will be represented by CXCL10 or CXCL9 in the urine. And so we know what other things they measure, BK nephropathy being actually a really important confound or cause of acute graft inflammation that is also associated with increased CXCL10. This is an adult study that was done looking at subclinical and clinical rejection on the right-hand panel compared to both IFTA and normal biopsies on the left-hand side, and you can see that they're strongly statistically different. There wasn't a significant difference for the borderline changes, and that's also the case for pediatric studies, although there is a very wide range of borderline, and we can talk sometime after as to whether borderline is borderline and whether some of them are rejection and whether some of them may be a state of quiescence. This has been validated in our center and in the Blydt Consortium for subclinical rejection in children. This is our own data with CXCL10. This is the data that we did with David and Mike looking at CXCL9. And David already talked about the D-score-2, which combines the CXCL9 and 10. And so these are both sensitive biomarkers that together are slightly better than either one of them separately that are validated for subclinical T-cell mediated rejection in children. The last one I'm going to talk about is the blood transcriptomics, and these are markers of alloimmune activation, and these are different combinations of blood gene expression profiles that either use microarrays or mRNA sequencing panels. And again, these are usually looking at the pattern of gene expression rather than any individual gene expression. So we know what they do in terms of reporting on the intensity of immune activation. And unfortunately, similar to the cell-free DNA, these typically seem to be trained on a combination of AMR and TCMR together, which to me doesn't make any sense because the molecular phenotypes of antibody-mediated rejection are totally different from the phenotypes of T-cell mediated rejection, as Phil's data would show. And this perhaps is why we have problems in terms of validating them in children. There hasn't been a lot of work done to resolve what else is associated with an elevated transcriptomic panel that's measured in the urine or in the blood. It has been validated for T-cell mediated rejection. These are a couple of studies that looked at that. You can see that there's elevation of this. In this case, it's the AlloMap kidney panel in the setting of T-cell mediated rejection. But there's really been no studies whatsoever looking at subclinical rejection. And you cannot apply the validity of the study in TCMR necessarily to people who are having surveillance biopsies unless you actually do the studies to look at those things. And although we're involved in one study that's seeking to validate this in children, there's no published data that would say that this is effective. So the last couple of minutes, I'm just going to spend talking about the need for intervention trials. And it's one thing to identify and validate a biomarker retrospectively using samples that we've either collected in real time or that we've had in our freezer. It's another thing entirely to then say we're going to use this test to monitor our patients in the clinic. So we really need to understand, is this test useful to both identify rejection and, more importantly, to change the outcome of our patient in terms of graft survival or patient health. So this is a list of all of the implementation trials that have been done to date. There's one for CXCL10, and there's another one or two that are underway, and there's none in any of the other areas. So I'm going to focus on what would be a good intervention study. This is actually the original protocol biopsy study that David Rush did now over 25 years ago. And they had a very simple study design. They divided the group in two and said one group gets the intervention of surveillance biopsies, the other group gets standard of care. And they went to see what happens to the amount of graft damage after a year and what happens to the kidney function after a year. And interestingly enough, when you use this type of monitoring, you actually identify a lot more rejection episodes, which maybe shouldn't be surprising because that's the whole point of it. And if you identify those rejection episodes and treat them effectively, you will have potentially better resolution of rejection. In the control group, they had many more cases of clinical acute rejection, which is to say rejection that needed to be diagnosed by indication biopsy, which presumably had gone through a subclinical phase, but only manifest when it was bad enough that it presented clinically. And what they were able to see was that the level of chronicity in the intervention group was better, and after 2 years, the level of graft function in the intervention group was better, which is what established what we now use as protocol surveillance biopsies in the clinic. This is an important study to mention because it was a purported negative trial of CXCL10, and so I always get asked about it, so I always put it into the slide deck. This was done by the group in Basel. It included 240 adults who had kidney transplants, and their intervention was to do CXCL10 monitoring at 3-time intervals compared to standard of care, which was none. They did not show a difference in terms of the outcome. However, there's a couple of really important caveats. First is that although they identified many more cases of subclinical rejection in the intervention group, they didn't always treat subclinical rejection, which kind of defeats the purpose. The second is that they didn't monitor to check whether rejection was resolved. So if they treat rejection, but they don't know whether rejection is better after you've treated it, you don't know whether the intervention has worked. And thirdly, acute rejection was actually one of their endpoints of the study. And so if you don't treat rejection and you don't check that rejection was treated, you shouldn't be surprised that you still have rejection at the 12-month time point. And so these are some of the limitations of this study. I think we learned a lot about how to do this type of study down the road. And I think hopefully the next version of this will be better constructed. So the last thing I'll say is just to summarize the 4 different groups of biomarkers that we had. The cell-free DNA is validated for T-cell rejection, and we understand what else causes graft damage, but it's not validated for subclinical surveillance and not in children. The urine metabolomics has a good profile in terms of a potential biomarker, but we have not submitted it yet to implementation trials, and that's something that we very much like to do soon. The urinary chemokines are now the subject of some implementation trials. We're about to start one here in Canada as well. And we're hoping that this, as a marker of tissue inflammation, will give us some good understanding of all things, all tissue information in our allografts, not just necessarily focused on rejection, which is, of course, one of the treatable forms of tissue inflammation, but also on BK nephropathy and subclinical acute pyelonephritis and other things that cause tissue inflammation. And then lastly, the transcriptomic profiles seem to be struggling a little bit in terms of not just, although they've established some validity for T-cell mediated rejection, they really haven't been validated from the standpoint of subclinical surveillance or in children. So with that, I'd just like to make the point that I hope that we can be critical consumers of these data, and that when we design trials to evaluate these types of biomarkers, we keep some of these things in mind. I think we need to insist that biomarkers that are intended for routine clinical surveillance really need to be validated within that context for us to be able to use them with confidence. There are several validated biomarkers close to clinical use, but we really do need implementation trials in order to evaluate how they're actually going to be beneficial to our patients. So with that, I'd like to thank the many groups that have supported us and funded us in the past, as well as the clinical teams that have supported us. So thank you all very much.